All right, let's begin. I'm Howard Wolinsky. I do the Active Surveiller newsletter for the last 3 years. I have 2,000 subscribers now and growing. Yeah, I appreciate if you could all mute. Today I'm getting backup help from Bill Manning, who's the executive director of the Active Surveillance Patients International. Jeff McClellan and David Keller are going to be monitoring the chat box. If you have questions, feel free to put them in the chat box. My able crew will be monitoring them. I'd say this is the time to begin. Okay, this program is the first program that I've ever held for this newsletter. I've done hundreds of them over the last, I don't know, 5-6 years, dealing with active surveillance and low risk prostate cancer. This program is intended to provide education on the latest developments in the field, not to offer personal health advice. Although I think some of you have questions that you're asking about your own experience, but will apply more broadly, and I think the doctors can sort that out. I'm grateful to the speakers today. Each will speak for about 10 to 15 minutes, and then we'll open up for questions. Our speakers today are true experts in prostate cancer, and for our purposes here, especially for lower risk prostate cancer and active surveillance. But I know we have people in the audience, and they certainly are welcome, who have more advanced prostate cancer. I think we can all learn from each other. I'm going to list off the speakers, and then I guess we'll do it in reverse alphabetical order in terms of listing them. Dr. Christian Pavlovich, who runs the active surveillance program at Johns Hopkins, and recently has co-authored a couple of studies, one on diet and one on confirmatory biopsies. I think it's really interesting, and but I imagine he will be open to more general questions. Brian Helfand, Chief of Urology at North Shore University Health System outside Chicago. He's not only a urologist, but also a molecular biologist. And those are the people who design all these blood and urine and spit tests. And I should disclose that Dr. Helfand is my personal urologist. Dr. Timothy Showalter, he's medical director of Artera AI, which has made news in the last year with its prostate test to help patients decide whether to go on active surveillance, but also whether they're candidates for androgen deprivation therapy. And finally, hitting cleanup is Dr. Jonathan Epstein, former chief uropathologist at Johns Hopkins, one of the world's leading pathologists. He's now based in New York and will be making his first appearance before a patient audience in almost 2 years. So Dr. Pavlovich, why don't you take it away?
Thank you. Thank you so much. Hopefully my audio is okay. I want to thank you, Howard, for inviting me to present these updates. And again, given constraints, I'll focus on 2 areas. First, I'd love to talk about diet. I think one of the questions I hear most commonly when a patient and I embark on their AS journey is, Doc, is there anything I can do to help prevent progression of my cancer? And while many of us give well-meaning advice regarding a positive attitude, healthy lifestyle, we really don't have much evidence, strong evidence, that these affect prostate cancer progression. Sure, a healthy diet and exercise are important for overall health, but specifically their impacts in men with prostate cancer have been understudied. What do we know? fairly robust data from the UK and other areas suggests that a more plant-based diet, vegetarian or vegan, for example, is associated with lower rates of prostate cancer. But this is not the same as saying that a plant-based diet reduces prostate cancer progression in men on surveillance. And it's certainly not evidence from randomized trials. Really, there is no level 1 evidence that shows that a specific diet can prevent prostate cancer or prevent prostate cancer progression. What do I mean by level 1 evidence? This is, again, evidence gathered from a randomized study where patients are randomly assigned to 2 or more groups, interventions, and to a control. Are such trials feasible in active surveillance? Well, yes, and there have been at least 2 over the years, one many years ago and one more recently, that took a group of men on AS and randomized them to dietary and/or lifestyle intervention. Way back in 2005, Dean Ornish and colleagues took a motivated cohort of Californian men on AS and randomized them to a very intense diet and lifestyle program for a year. And in this small study, they noted some beneficial effects on PSA reduction and on some other health parameters in the men randomized to this intense program that was vegan, strict exercise program, and wellness and meditation. Unfortunately, the authors did not, to my knowledge, report on prostate cancer progression rates themselves, on biopsy outcomes, a lot of the stuff that more hard scientists would want to know. And essentially, the study has been lost to time without clear follow-up, as far as I know. Much more recently, in 2020, Dr. Kelly Parsons at UCSD and colleagues published their MEAL study, MEAL, in JAMA. And this is where men were randomized to a recommended diet of 7 or more daily vegetable servings, or a control group, which received information about diet, but no specific, instructions, and they weren't checked on with phone calls. Unfortunately, these authors were not able to show an effect on prostate cancer progression by either PSA or by biopsy or pretty much any parameters, but they were able to show that men on AS could accept randomization, which is tough for Americans, and they could implement important changes to their diet, which is also key because a lot of us get into our same old patterns. And over the last few years, we've seen more and more retrospective studies, though, looking at healthy diets and prostate cancer prevention. Again, progression, not randomized studies, but looking at surveillance cohorts. Researchers have looked into the Mediterranean diet, the vegetarian diet, vegan diets. They've looked at the healthy diet as per the dietary guidelines for Americans published by the USDA, which get updated every 5 to 10 years. And using those guidelines, a healthy diet can be calculated into a healthy eating index score from 0 to 100, with 100 being the best. There's good data from MD Anderson, where clinicians have shown that there's a suggested benefit to a higher healthy eating index score. There's a suggestion that a Mediterranean diet might be beneficial, and that's healthy plus a little alcohol consumption, believe it or not. But their findings did not quite reach statistical significance. And this suggests that their results could be due to chance or due to just having a small study group or very small effects. The Canary Pass group from Seattle has also done dietary analyses in their larger surveillance cohort, but they've not been able to show that a healthy diet reduces progression of prostate cancer, whether it's a Mediterranean diet, a heart-healthy diet, or a higher healthy eating index, or HEI. So that was the state of things till late last year, when we turned back and analyzed our data at Hopkins. Our program was started back in 1995, and we've started giving dietary questionnaires to men around 2005. So now we have close to 1,000 men with self-reported dietary data tabulated into a healthy eating index score. And we were just able to show in a paper in JAMA Oncology, written by one of my residents, Dr. Su, that a higher healthy eating index score correlates statistically with a decrease in prostate cancer grade progression in men on surveillance. Men with grade group 1 prostate cancer and higher HEI dietary scores had statistically fewer upgrading events to grade group 2 or higher, or to grade group 3 or higher cancers, the latter being the cancers that really necessitate treatment. In fact, Our data show that for every 25-point increase in the HEI, a man can reduce his chance of prostate cancer progression to grade group 2 or worse by 30%, and progression to grade group 3 or worse by close to 50%. Even smaller dietary improvements of 12.5 points on this scale could beneficially reduce upgrading rates. We also assessed the inflammatory potential of a diet, but we're not able to show any effects of reducing pro-inflammatory diets on prostate cancer progression. So what is this diet we assessed? It's basically a varied diet with rich in natural nutrient-dense foods, including whole grains, fruits, vegetables, lean proteins, dairy and meat in limited quantities, and restrictions on total fat, saturated fat, sodium, and cholesterol. As an example, on a 2,000 calorie a day diet, you would have to have at least 2 cups of fruit and 3 cups of vegetables daily to score high on the HEI. I refer men to the Dietary Guidelines for Americans, which provides a helpful summary of how and what to consume to get closer to a more optimal eating index. So now I think we can say with high-level retrospective evidence, though not randomized level 1 evidence, that healthy diet can help prevent progression of prostate cancer from low grade to higher grades, and that the healthier the diet, the more beneficial the effect is. Finally, something positive to tell men on surveillance who are interested in improving their own health that is backed by years of accumulated data. I'll shift focus to another consideration, and that is prostate biopsies, which, again, in the minds of most of us are an important part of surveillance, and in the minds of most patients, other than prostate cancer progression, probably one of the more dreaded parts to surveillance. Well, there's good news on that front. First of all, level 1 evidence has convincingly shown that the transperineal approach is safer and equally effective as the transrectal approach to prostate cancer detection. And in the large randomized study called the PREVENT trial, researchers from Cornell, Northwestern, Johns Hopkins, and other institutions teamed up to show that transperineal biopsy men had fewer infectious complications than men who had their biopsies transrectally. In fact, there were 0 infections in the perineal group with no antibiotic use at all, whereas there was a 1.6 rate of infections in the men who had transrectal biopsies, despite targeted antibiotic prophylaxis in all men. And importantly, no difference in cancer detection, et cetera, and if anything, more complications in the transrectal arm. So clearly, the transperineal approach should become the standard of care if you have to undergo biopsies, for example, like serial biopsies in surveillance. And last year at Hopkins, we studied when a confirmatory biopsy should be done for men considering surveillance. This has been a long-standing recommended protocol. About a year after biopsy, NCCN suggests you should have a biopsy to make sure nothing was missed. We recommend that an MRI be done before that confirmatory biopsy. So we studied men who had the MRI and compared men whose MRI was positive and showed a target lesion versus men whose MRI was negative. We found that the rate of cancer upgrading at confirmatory biopsy was 27% with positive MRI, but only 9% in men with the negative MRI. And upgrading to unfavorable intermediate risk disease and to grade group 3 or higher was also 3-fold more likely in men with a positive MRI than men with a negative MRI. And we found that systematic biopsies caught about 1/3 of the upgrading events. So when we do a biopsy, we suggest targeting plus some systematic cores as well to not miss something significant, although that data is, sort of a little bit controversial. So ultimately, our data suggests that in men with low-grade cancer who have a clean MRI, one could delay the confirmatory biopsy for perhaps 2 or 3 years, whereas men with a positive MRI should really have that biopsy within about a year of their diagnosis. So in summary, I think 24 was a good year for most men on AS, with new and important information coming out. Number 1, that a healthy diet can prevent the progression of low-grade prostate cancer to higher-grade prostate cancer. And I refer folks to www.dietaryguidelines.gov. Doesn't have to be vegetarian strictly. You don't have to avoid milk completely, et cetera. Number 2, biopsy should be done transperineally, ideally. And number 3, confirmatory biopsies can be delayed somewhat for men with a negative MRI.
Well, thanks.
Thank you. And that's
Thanks,
it for me.
Dr. Pavlovich. Now we'll move on to Dr. Helfand.
Yes, again, thank you, Howard, for the invitation, and certainly always a pleasure to talk to this group, even on Saturday morning. So hopefully you all are awake and enjoying the new year. So I think, as Howard previously mentioned, my interest and expertise is really focused in on biomarkers, and specifically both RNA and DNA-based so-called genetic or genomic biomarkers. And I think before we really get into that or understanding that, it's important to understand that there is no holy grail in active surveillance. And I mean that by, or what I mean by that is that there is not a single test in general that is going to tell you you are the most ideal candidate. You will never progress or get upgraded on active surveillance, but rather it's an important, what I kind of refer and have published on, what we call a multi-parametric approach. Use multi-level data, whether it is a biomarker that's obtained by measuring a protein in your blood, in your urine, by looking at specimens to extract a DNA or protein or RNA-based signature, overall morphology of how the cells look or the pathologic characteristics, or the MRI, whether it's positive or negative. These are all biomarkers, meaning information that we get from multiple different media to really kind of make a better decision. Again, remember, PSA is not a great indicator for how your cancer is doing. You should be looking at other markers to help inform us better about that tumor biology and behavior to see if that's actually progressing or not. And so I think the original true biomarkers or genetic biomarkers, again, referring to tests that are extracting signatures, really were all RNA-based signatures. And again, not to bore this group with kind of basic cell biology, but you have DNA, which is in every cell of your body, that's actually can be turned into RNA, which ultimately make the proteins or the actual functional building blocks that make the cells function the way that they're supposed to behave. And the original tests, and actually one of the first tests that became really commercially available and had that potential to change the ground, happened many years ago, around 2010, 2011, was a test at that point called Oncotype DX, which is now called the Genomic Prostate Score. And basically this looked at a RNA-based signature within the prostate tissue from biopsy that predicted how well patients would do on active surveillance, the presence of ultimately adverse features if this patient would undergo surgery or radical treatment at later times, etc. And since then, many other tests in the space, Prolaris, Decipher, and now Artera AI, which is not really looking at RNA, but you'll hear a little bit about how that technology works, but is all looking at basically what is happening, the biology of the cell and of the prostate tumor cells. And this is providing additional information that can better stratify a patient's risk of progression over a 10 or 15-year period. Now, none of these tests have really ever gone head to head. I do believe in these tests. On the other hand, I do want everyone to keep in mind that if you have these tests, do not make that decision, yes or no, that you are the ideal candidate for active surveillance or not, but rather use this information as another piece of data to support that decision. So take that into account with your MRI. Take that into account if you have other biomarkers, the amount of cancer that's present on a tissue, any pattern of Gleason pattern of 4 or higher. I mean, these are things that you can collectively take together to help help make better, more informed, multi-parametric, if you will, type decisions. So again, I think the promise, especially in the RNA world, is that I think we will still be seeing these tests. I think, again, having conversations with your care provider to better understand how these tests relate to you or your diagnosis should be had. But again, emphasize the point that these should be used collectively with other information that we have to make that better decision about your suitability for continued active surveillance or not. But I do think that, again, as we move on to 2025, I think the potential of how these are going to be incorporated into this multi-parametric paradigm will be had. I think moving or changing topics a little bit, and what excites me the most is our accumulating data in terms of DNA and what we are extracting in terms of how we can use our DNA analysis, the type of DNA that is passed from generation to generation, something we refer to as germline DNA. That is in every cell in your body. That's the stuff that, again, we inherit from our parents that make you, and Howard him, that ultimately you pass on to your children and family members. And so it's understanding what those blueprints are in every individual that can help us actually understand the behavior or your susceptibility not only to prostate cancer, but to potentially your suitability on active surveillance. That is in very stark contrast, if you will, just to make sure everyone's on the same page, is that you can also analyze the DNA in cells within tumors. These are what we call somatic DNA that is extracted from the tumors that is unique to that tumor, meaning that as cancer cells progress, they accumulate changes in their DNA. Those changes are only in those tumor cells. Those are passed on, and they can change within tumor types. But those are what we call somatic DNA, and not necessarily what I'm going to be talking about today. They do have utility in active surveillance, the somatic DNA, because again, some of those markers that we can detect in those DNA are prognostic. But for the purposes of this conversation today, really focused in on germline DNA. And what we have learned by doing many years of study of DNA is that there are certain gene mutations that do predispose to more aggressive disease. And I think, again, the prototype of many of this has really evolved from BRCA1, BRCA2, those type of genes, right? Because we became familiar with the concept of testing for germline DNA because in women and breast cancer, that there are mutations, certainly in those what we call DNA repair genes, but really became popularized with the knowledge of mutations within BRCA1 and BRCA2 that increase women's risk of breast cancer and certainly aggressive or lethal type of breast cancer. And we, for many years, were focused in on many of these genes, but we didn't really see a lot of signals in terms of their association with prostate cancer and or aggressiveness. But it really was the evolution of DNA sequencing technologies and the availability of biomarker data that we were able to really identify that men who had metastatic or lethal type prostate cancer, they were enriched in a lot of these type of DNA repair mutations. And it turns out it's not just BRCA1 or BRCA2, but there is a whole list of DNA repair genes and other genes we call mismatch repair genes that do increase the risk of prostate cancer and as well as aggressive disease. Now, there's a list of over 150 different DNA repair genes, but it turns out that most of these are not necessarily relevant to prostate cancer or certainly active surveillance. But there are ways, and this is what 2024 has really imparted to us, is that there are ways to look and distinguish those genes which do increase the risk of prostate cancer versus those which increase the risk of aggressive disease. Because while the data still is accumulating, and Dr. Pavlovich and myself are trying to sort through some of this, that if you had a gene mutation that increased your risk of aggressive disease, meaning that of grade group 3, the Gleason 4+3 or higher type of cancer, or certainly metastatic or lethal prostate cancer, you may not be the best candidate for active surveillance. And from many different sources and types of studies, what our group has really concluded thus far, although again, that information is still forthcoming specifically in the active surveillance cohorts, is that gene mutations within BRCA2, ATM, CHEK2, NBN, PALB2, and potentially some of the mismatch repair genes known as MSH1 or MSH6 do increase your risk of aggressive disease. And again, while we don't have those data in active surveillance in large cohorts yet, because again, remember, these gene mutations are relatively rare in the population, but we are jumping to some of that conclusion that you are at significantly higher risk of developing worse prostate cancer over time and are certainly potentially more likely to fail active surveillance. So if you have one of these type of mutations, should you undergo active surveillance? Again, the jury is still out, but certainly that discussion between you and your caregiver should be had, and certainly putting that into a multi-parametric model, which is incorporating all the other factors, should also be considered at that time. I do think, again, one of the beauties of 2024 has demonstrated that genetic testing, germline DNA testing for many of these type of genes should be had and should be expanded. The current NCCN guidelines are relatively limited in terms of who is a candidate for getting germline genetic testing. Certainly the cost of everything has gone down. And so you can, even if you weren't covered by insurance, get these tests for relatively cheap in the order of about $200 these days. On the other hand is with the guideline expansion, more and more patients should be covered. And what I say that is that there's been a push based on a prospective trial, which was a national trial that demonstrated that only 60% of patients who met guideline criteria had gene mutations, but another 40 to 50% of men who had those mutations were actually, based on the current NCCN guidelines, would have not been offered testing. So I think we ultimately, there's a push right now. We certainly have a manuscript in at JCO right now that is trying to expand those guidelines. And I think 2025, we'll see more universal or uniform germline genetic testing that's offered. The last little part to talk about that I do think that will come forth in 2025 and beyond is the use of certain other genetic DNA germline biomarkers, things that we call single nucleotide polymorphisms. These are what I refer to as more of blips, if you will, throughout your DNA. And everyone has many of these blips. There's over 3 million of them throughout everyone's DNA. And there are blips that are that in part increase susceptibility to prostate cancer. There are others that increase risk for heart disease and colon cancer and osteoporosis and depression. So you can actually use these to help stratify what your risk of certain diseases are. And for the most part, if you're in active surveillance, you already have cancer, and these blips, if you will, may not be that relevant. And what I mean by that is that we have the ability now to count up the number of blips that an individual has for prostate cancer. You can count them up and create a score called a polygenic risk score. And this can be used to estimate your susceptibility to prostate cancer. So if you have a lot of these blips, you may be able to tell a patient that you are a fourfold higher risk of prostate cancer, or if you only have a few of those blips, you may tell a patient that you're actually at 80% lower risk of developing prostate cancer. Your score, your polygenic risk score, is also associated with the risk or the age that you will likely develop prostate cancer. So if you have, again, a very high score, you may be on average about 11 years younger than those your age counterparts who have a very low score. So again, can be used to help stratify screening. I think 2025 will be using a lot more of these scores in the primary care setting to help estimate, when to start screening patients. But I also think if you're on active surveillance, a lot of polygenic risk scores for other diseases that may be relevant may be actually applied to you. Certainly, we have worked with a company called GoPath to really help develop some of this. There are scores for BPH. If you develop a more aggressive form of prostate cancer and you need hormone therapy, there are some of these scores that will tell you your responsiveness to the hormone therapy, potentially your risk of osteoporosis if you need hormone therapy, depression, et cetera. So I think we're going to start seeing a whole bunch of increased utility of these scores as we move forth, because largely this is reflecting a lot of the other fields in medicine right now. Currently, these are being applied in cardiovascular space and other areas of medicine to help understand patients' outcomes and risk. So again, looking very briefly at what this year holds before us, I think, again, is incorporating that multi-parametric approach, using multiple media to really extract a true biomarker signature that's going to help guide us in better decision making, but also using these tools in more novel ways to not only focus on prostate cancer, but also look at associated outcomes. So thank you.
Thanks, Dr. Helfand. Now it's Dr. Showalter, please. And he has slides.
Yes, thank you. It's thanks for the opportunity to speak today, and congratulations on such a great turnout on a Saturday. It's pretty impressive. I want to also acknowledge my very kind 15-year-old daughter who let me pause at a Barnes & Noble after her swim meet to be here today with you. So much appreciated. I'm joining you from Virginia. So I'm a radiation oncologist at the University of Virginia. I practice part-time, and my primary role is as Chief Medical Officer for Artera. And Howard invited me to give an overview of what the 2024 update is within the role of artificial intelligence and active surveillance. So I'd like to touch briefly, very briefly, on sort of representative updates within diagnostic pathology and radiology, before sharing what we did at Artera in 2024 and what our plans are as we go into 2025. So first off, we get asked a lot about what's the role of AI in diagnostic pathology. I wanted to highlight one really strong paper that came out as a collaboration that involved Dr. Pavlovich, as well as others from Johns Hopkins University, and in collaboration with another company called Matrix. And in this study, they basically looked at the role of a deep learning pathology algorithm using whole slide images to regrade or basically perform AI diagnostic services on specimens from 2 active surveillance cohorts. And what they were able to show is that reclassification based on the deep learning algorithm of grade group 1 to grade group 2, essentially, for the initial biopsy specimen for patients enrolled in active surveillance, successfully identified those patients who went on to experience rapid or extreme reclassification while on a course of AS. So this kind of addresses what I think the promise of doing the best job we can upfront when someone has been diagnosed with prostate cancer and is contemplating active surveillance. It really is potentially impactful to identify those patients who are going to progress. And not everyone gets to have their pathology slide read by a true expert pathologist. So the other exciting thing about a deep learning algorithm like this is that it's potentially scalable, really, not only in the US, but globally. Another interesting point about this study is that they focused on cohorts that represented the pre-MR and post-MR era. So as you know, the biopsy yields may differ between those two cohorts. So I think more to follow for this. I think the basic gist for where the role of AI in diagnostic pathology stands in 2024 as we go into 2025 is that it's viewed as a useful tool to supplement pathologist performance, and certainly not a replacement. You still need expert pathologists reading your specimen. Moving on to AI and diagnostic radiology. There are FDA-cleared tools that exist for AI-based MRI diagnosis and grading. This is a dynamic field. I shared here one of the many publications pertaining to the use of artificial intelligence, or there may be another term that you'll see in the literature, radiomics, meaning essentially computer-based analysis of MRI information. This is a great article that you may wish to read. I will cut to the chase. It's got a provocative title that says, "Should we jump on the bandwagon?" I would say the authors concluded that that AI is not ready to be fully routinely implemented within radiology interpretation of MRI. I do think its current status is that the algorithms have shown that despite limitations in the robustness of their validation, meaning there could be some variation in the data sets they've looked at, that there's certainly a useful tool for radiologists. And just as the case is for its use in pathology, AI is certainly not going to replace radiologists at this point, but this can be a useful tool. And we may see some signatures emerge over time from MRI that can serve as an additive on top of the information that a human radiologist may provide. So we made some updates at Artera in terms of providing information directly geared towards active surveillance decisions. And 2024 was a big first initial step for us into the space, and we viewed it as a real priority for the year. You'll see that I'll share with you that we're not done yet. We think we have more to do to deliver all that we can in this space. As a reminder, for those of you who are not familiar with Artera, we are a digital pathology focused company that uses machine learning approaches that factor in primarily information from digital pathology slides, but also clinical data to develop tools that inform cancer therapy personalization decisions. So think of us as like a risk stratification tool after someone's been diagnosed, or providing specific information regarding a clinical decision. For those of you who are sort of curious at what's going on, so basically under the hood of our tool are computer vision, artificial intelligence platforms that are basically analyzing digital information from the biopsy slide. And what I've shown here is an example of an intention heat map. So it just shows the area of attention on a biopsy core that our models are paying attention to. I generally describe this as really focused on the area of highest grade tumor and the surrounding stroma, and providing risk stratification and predictive information from there. Some examples of features to think about are, cribiforming and other sort of patterns that a pathologist might readily describe. Our AI tools also include some features that the AI model has identified that haven't really been clearly described in the literature and are occurring surrounding the tumor itself. So there's some additional biological information. While Dr. Helfand was talking, and I think communicating the importance of DNA, and I also slipped in to my presentation a slide from FooTrans group's presentation at the ASTRA annual meeting this year, which showed an interesting correlation between genomic sequencing data with described mutations correlating with the Artera AI score. So there's clearly the AI is interpreting tumor morphology or the appearance of cancer underneath the slide. And as you can expect, what's driving that is really it ultimately all comes down to these sort of genetic underpinnings of what's going on with cancer. And so, we found that our scores are also, as you can predict, associated with the predictable, DNA findings that are both in the DNA damage repair sort of findings like Dr. Helfand described, and then for the more favorable disease that, as predicted by the Artera test, we find some DNA findings like an SPOT mutation that's associated with better behaving cancers, essentially. So it can be a useful tool in that approach. In 2024, Artera released an active surveillance insights update. And this reflects our first step. We viewed active surveillance as a really important area where we didn't want our test report to be silent on that. It's such an important public health need. And where we are right now is that we updated our test report during the summer for NCCN very low, low, and favorable intermediate risk disease, include this added box here called active surveillance insights, which gives sort of a risk estimate of where that patient falls in terms of their risk profile relative to other patients who have good outcomes managed with active surveillance, and describes the association of our test findings with adverse pathology for the patients who are on active surveillance for a while and then maybe go on to get a prostatectomy. We represent this as it's basically our core module or core prognostic information that's otherwise available in our test and that's been available for the past couple of years, and we frame how the individual patient's risk compares to other patients that we've profiled in this cohort. So the idea is to give you a general, relative assessment of the risk and understand, like, my cancer is pretty typical of a lower risk patient who's well managed on active surveillance, or maybe I'm getting closer to the borderline and we might want to be more careful with active surveillance approaches. As Dr. Helfand alluded to, we're not viewing this as a single test that would drive decisions by itself, but it's another data point that would be used for more of a multi-parametric approach. It is not a new model. So this is the same model that we presented before. But what this shows is how our test performs in a active surveillance managed cohort, essentially. It can be a useful tool. We will be publishing results. We rushed to get this information out as soon as we had double checked the results and felt like they were ready to be released. We have not yet published much of this work, so I wanted to share a little bit of what we're looking at. This group of patients is included in our expanded cohort that we'll be publishing this year. And what we've been able to show in 2024 is that our risk assessment, our risk stratification performance really applies throughout the continuum of prostate cancer. And just, the other update for us in 2024 is that we are, continue to be supported by NCCN guidelines for all risk groups. And then lastly, I just want to cover quickly, I know we're running short on time, but just to look ahead to what we're doing in 2025. So you're going to see some publications from us, at least 3 separate research publications about how our tool performs in active surveillance managed cohorts. So meaning our prognostic test in a cohort of patients who is managed with active surveillance. We'll also be publishing a separate report that reflects a multi-site cohort, several thousand patients from Artera's FDA application for our software as medical device approach. And then we are not done yet. We view this as our first step in active surveillance. And we also want to focus on developing a new model that is specifically tailored to predicting risk of pathological progression while on active surveillance. I think it's not the all-encompassing holy grail, but I think for what Artera can do, I think that that's going to be an even stronger contribution than just showing our core test performance in that group. So you'll see a lot more to come from us this year, at least 4 publications coming out describing a lot of this validation evidence, and then hopefully some additional model development work as well. So I'll stop there and save time for Dr. Epstein.
Yeah, thanks, Tim and Dr. Epstein. Also, I may be asking our speakers if they'd be willing to stick around a little bit afterwards if we start to be in a position of not answering everybody we can. So Dr. Epstein, you're the power hitter. It's up to you now. Fourth.
I appreciate the invitation, Howard, and it's great again to speak to the men with prostate cancer and active surveillance. So first, let me just say almost all of you, I would assume all of you, have been diagnosed with prostate cancer. And before talking about the pathological features of the cancer itself, it's critical to make sure that you actually have an accurate diagnosis of cancer, in that one might assume once a pathologist diagnoses cancer, it should be straightforward, it should be objective and 100% accurate. Unfortunately, there are a lot of mimickers of prostate cancer, and there are some times when prostate cancer is overdiagnosed, when in fact a man does not have cancer. So what I would recommend for men, given that before going forward with treatment or even on active surveillance, the first step, if I were diagnosed with cancer, would be to get a confirmation that the diagnosis is accurate by sending it for a second opinion. Because again, if your diagnosis is incorrect, everything going forward will be incorrect. Now, once you're diagnosed with cancer, and in terms of are you a candidate for active surveillance, some things have changed over the last year or so. One is, there's been a de-emphasis on cancer volume. So on the initial criteria that we proposed for ideal candidates for active surveillance, cancer volume, number of cores involved by cancer, the percentage of the core involved by cancer was one of those factors. I think now with MRI, where volume of the cancer, the number of cores with cancer, I think that should be de-emphasized in terms of the extent of the cancer. More importantly is the grade of the cancer and certain other pathological parameters of the cancer. In terms of the grade of the cancer, again, numerous studies have shown there is subjectivity in grading of cancer, both undergrading and overgrading. So it is, again, critical to get an accurate reading on the pathology. One also can't assume just because you're at a good institution, top-notch, international, nationally recognized institution, that the pathologist reading those slides may not be an expert in prostate pathology. Likewise, you could be in a smaller hospital and they may be an expert in prostate pathology. So unfortunately, you choose your urologist, you choose your clinicians. Most of the time, you're not choosing your pathologist, and you don't know where your pathology is going to. In terms of AI, I think there's a few things to keep in mind at this early stage of AI in prostate cancer diagnosis and grading. First, it's not being used clinically at this point in time in general, with rare exception. Second of all, there are a lot of AI platforms out there. Each AI algorithm is based on pathology grading, for example, the slides, and that basically tells the AI what the grade is eventually. So the AI is only as good as whoever is grading the tissue for the AI platform. Second of all, unfortunately, in pathology, there's just tremendous variability in between laboratories in terms of how slides look. Even within a lab on a given day by day, how slides will appear, such that if the AI is trained on a certain data set of slides from, let's say, one or two institutions, how that AI might work then from another lab where the slides look totally different, may not necessarily be as accurate or the same. The other thing that we have in pathology that we don't have is in a lot of other branches of medicine is what we call artifacts, where on the slide, whether it's tissue folds, tears, thick sections, etc., is something that, again, you need somebody with a lot of experience to be able to look at those artifacts and to evaluate to get an accurate grade. The other thing that I think has changed over the last year or so, a couple of years with grading and AI, it used to be that any pattern 4 was almost a complete contraindication for active surveillance. And now we are recognizing that there are maybe some men with certain volume of pattern 4, certain architectural patterns of 4 that still could be candidates for active surveillance. So it's critical once you have a pattern 4 recognized, grade group 2, which is 3 + 4 = 7, to see what is that pattern 4, what percent pattern 4, for example, somebody with 5 or 10% pattern 4 within their 3 + 4 = 7 could be a candidate for active surveillance. I would argue somebody with 40, 50% 3 pattern 4 and a 3 + 4 = 7 would not be a candidate because that's bordering on a 4 + 3 = 7 or grade group 3. There's also different patterns that give you a Gleason pattern 4. And what's growingly recognized is that what's called a cribriform pattern 4 is a more adverse morphological feature. Cribriform comes from the word sieve, S-I-E-V-like. Think of it like Swiss cheese, basically a sheet with little punched out holes in it. But even within a cribriform pattern, there are kind of more adverse types of cribriform patterns and others that may not be as adverse. And so there's, again, tremendous variability amongst pathology reporting. A lot of pathologists do not report percent pattern 4. They don't report if there's cribriform pattern 4. And if they report cribriform pattern 4, they may not substratify cribriform pattern 4 into those that are more aggressive. So when I'm giving a report, I will give the percent pattern 4, also state whether there's large cribriform glands of pattern 4. And there are different definitions of large cribriform glands of pattern 4. I use one that is objective, that also correlates with, in studies, a more aggressive behavior, such that if one did have these large cribriform Gleason pattern 4s on a biopsy with a grade group 2, in my opinion, that would be argue against active surveillance. Another factor that is an adverse parameter that you don't see that often in active surveillance men, but nonetheless can be present, that should be a contraindication in general for active surveillance, is intraductal carcinoma of the prostate. Numerous studies have shown this as an aggressive marker when you find intraductal cancer. But again, there is subjectivity and inter-observer reproducibility issues with the diagnosis of intraductal cancer of the prostate. I'm currently on an international consensus panel working on trying to develop criteria where hopefully there will be greater reproducibility and consensus on the diagnosis of intraductal cancer. The diagnosis still uses our original criteria that I worked on many years ago. That's still currently the accepted criteria for intraductal cancer. You may also hear a term called AIP, or atypical intraductal proliferation. And what AIP is, it's kind of a broader lesion that's worse than what is called high-grade prostatic intraepithelial neoplasia or high-grade PIN, kind of stratifying between high-grade PIN and intraductal cancer. Some of these AIP lesions border on intraductal cancer. Some AIP lesions are less worrisome. Consequently, if you're diagnosed with AIP on your biopsy in addition to cancer, I think it's important to discuss with a pathologist this given AIP that you have, is it closer to intraductal cancer where I should be maybe concerned about staying on active surveillance, or is it an AIP that's not as worrisome, closer to high-grade prostatic intraepithelial neoplasia, which should not be a factor in terms of staying on active surveillance. Another factor that actually we did a study with Dr. Pavlovich with Johns Hopkins, showing the importance of perineural invasion once you're on active surveillance. So having perineural invasion, along with a higher PSA and PSA density, is a risk factor for having progression subsequently. And so again, it's not if you have perineural invasion, you should go off active surveillance, but as everyone has, all the other speakers have mentioned, it's kind of a multi-parametric or multifactorial approach. Having perineural invasion is somewhat more of a worrisome feature. So I would argue that intraductal cancer truly is a contraindication. Large cribriform cancer is a contraindication for active surveillance. Perineural invasion is not a contraindication, but is something that is more worrisome, and maybe, for example, one should have a rebiopsy in a closer interval than if, for example, perineural invasion was not present. The other thing that I'll mention just from my broad experience dealing with pathology of MRI biopsies is no question MRI has been a tremendous game changer in terms of being able to target areas of higher grade and identify areas of higher grade, but it is not foolproof. Meaning, as Dr. Pavlovich mentioned, you still need a systemic biopsy, systematic biopsy, where you're sampling the areas outside of what the target lesion is, because some cases the target will miss the higher grade lesion entirely, and the other biopsies will be those that identify the higher grade cancer. The other thing that I would stress is that, and I see this literally every day in my practice, that you will see a case of where there's low-grade cancer everywhere in the biopsy. It would look like this would be the ideal candidate for active surveillance. And there'll be one tiny area on one with very high-grade cancer that easily could have been missed. And again, it's not a matter that I'm trying to, scare or put fear into everyone on active surveillance, but just the reality is, with all our techniques that we currently have, even the molecular tests, et cetera, we still have this problem of undersampling the worst area of the prostate cancer, because the worst area can still be a very tiny area, and the needle biopsy still only sample a minute fraction of the prostate. And what I think I would stress is the importance of repeat biopsies, because the only way in some cases you will identify that higher grade component is on repeat biopsies. So I think, again, men on active surveillance should feel some reassurance if they have good pathology and everything else is favorable, but should still recognize the need to be followed carefully, be in an active surveillance program, and to undergo repeat biopsies to try to identify the worst cancers if it's present there. And I think at that point, I'll stop and, I guess we'll go on to questions.
Yeah. Well, thanks, Dr. Epstein, and thanks to all the speakers. And what we're going to do now is go to questions and answers. I have received some questions via email myself, and I have some of my own based on the talks today. And then we'll switch back and forth between myself, Jeff McLennan, and David Keller, who have been monitoring the chat box. But I'm going to start with, I think, 3 questions of my own. Okay, Dr. Epstein, you mentioned getting a second opinion. And I know a lot of men do that, but if you start off initially with a Gleason 6, should you declare yourself good and not bother, or do you still recommend getting a second opinion with the biopsy, no matter what?
I would definitely recommend getting a repeat biopsy. There are some men diagnosed with the Gleason 6, number one, may not have cancer, or there could be Gleason 7, grade group 2 in there, which was not graded correctly by the pathologist. So, I would say the majority, 80–90%, if you're diagnosed with a grade group 1, will be a grade group 1 on review. But, 10% may be grade group 2. And that could change potentially, how you go forward. And, again, everything going forward is based on an accurate diagnosis of your cancer and the grade. And it's a small investment with a second opinion, and most insurances cover it, to have the right diagnosis and feel comfortable going forward with that.
By the way, what is the inaccuracy rate? Wait a minute, somebody said.
Which group is this?
Yeah, could you, okay, sorry about that. We were getting some feedback. And of course, I lose my train of thought with any feedback. Sorry about that. But let me switch over to, okay, I remember now. Dr. Epstein, you alluded to that there's some inaccuracy with the biopsy. What percentage, what are the odds, or however you want to express it, that somebody's getting the wrong answer?
So in terms of grading, there's about a 20%, I would say there's about a 20% chance of a different grade when viewed by an expert when your biopsy is reviewed. So it's not insignificant in any respect.
So it could be an upgrade, but it could be a downgrade.
Correct, yep.
Okay, I'm going to switch over to Dr. Helfand. Should all men diagnosed with prostate cancer undergo germline testing or risk score testing?
So, I am biased, and certainly I don't think the guidelines right now are necessarily supportive of it. On the other hand, is the cost of genetic testing is so reasonable these days. I don't think the current guidelines really capture who is most likely to harbor a pathologic germline mutation that could in part affect prognosis and how we treat you. And I think the earlier we get this information, the better it helps to understand and complete, kind of a picture of your underlying biology of how you're born and certainly how your tumor may behave. And in addition, if you do have a mutation, not only will it help, make better prostate cancer decisions, but it may influence screening for other cancers that you still may be at risk of for you as well as your family members. So I really do take the stance that there is no harm to testing, and the earlier we get, the better it is. Understanding that right now it is, somewhat still limited based on the current guidelines and insurance reimbursement. But again, because of the decreased costs and decreasing continued costs, I still think that it's very reasonable to get, or at least offer or have that discussion with most patients.
Well, I have a follow-up to that. In case you didn't notice, this is an international crowd, and we have people from as far away as Moscow and England and Canada, of course, and Ireland, and I don't know where else. But I get the sense that outside the United States, there isn't that much enthusiasm for genetic testing. Am I wrong, or can you explain?
It really depends on country and availability of testing and testing facilities. There is a lot of enthusiasm right now in Europe. In fact, certainly in Britain, there's a huge effort to more mass, if you will, screenings there, as well as Finland and Sweden. There are actually a lot of national efforts to incorporate genetic tests into routine prostate cancer screening before you're even diagnosed. And so, again, those areas have a good crux of scientists who have really investigated this and who've had influence and guidelines over there. But certainly as we expand toward Moscow, et cetera, and certainly Africa, even Australia and some other continents, just the availability of testing is a lot more limited. So unfortunately right now, that is still variable based on where you are. And the problem even of using a lot of US-based companies is that there are still regulations in terms of biospecimen transport across country lines, et cetera. So sometimes that can be limited as well.
I got you. I'm going to have one more question, then I'm going to switch it over to Jeff. And this is for Dr. Pavlovich and for Dr. Helfand. I was on a consensus panel myself. Yeah, they let us patients in sometimes. And this was from the Movember group, which is very patient-oriented. And Dr. Carolyn Moore, urologist from UK, was the principal investigator. And one of the conclusions from our consensus is that digital rectal exams should be eliminated. And so I'd like to ask the two urologists what they think. I don't know what Dr. Helfand thinks, but I do know what Dr. Pavlovich thinks. But why don't you two give your opinions and see if you have a consensus amongst yourselves?
I certainly think that the continued use or routine use of digital exams in a lot of settings is probably not as useful, right? I think, unfortunately or fortunately, a lot of physical exam skills, have really been replaced by a lot more advanced imaging and molecular, kind of test results. Certainly, I would put a lot more faith into an MRI than I do into a digital exam. However, really upon meeting patients and certainly even monitoring over time, I still do the exam. And the reason being is that, I still think it gives me a relatively rough estimate of prostate size. And so certainly that's something that to kind of roughly estimate PSA density as a very quick and metric, does at least initially put me more or less at ease when I see a patient who's undergoing prostate cancer screening. And certainly, obviously, looking for any type of nodule that may or develop over time. Do I think a lot of the primary care docs should be doing this? No, I haven't really seen a lot of utility, and certainly the more prospective studies have really supported that there's not a lot of utility in that setting. But, you know, if by using my so-called multi-parametric approach, if I was going to rank the digital exam, I'm going to put it toward the bottom in terms of the utility, how much that's influencing.
No pun intended, I guess.
Yeah, exactly. Perfectly anatomically placed there.
And Dr. Pavlovich, are you going to disagree?
No, I think Brian pretty much put his finger on it. Again, no pun intended.
Another pun, you got to
Yes.
stop.
But you know, we're not primary care physicians. We're not screening. Our men have cancer. Our men worried they have cancer. Brian mentioned that, you know, genetic testing is getting cheaper. Well, this is really cheap. I mean, this is, you know, 10 seconds, you know, it's over with. Yes, it's not a pleasant exam to most patients or to physicians, but it is something we do on an annual basis in our surveillance group. It's very rare that that's what tips us off that there's a change, you know, but there is the occasional man, it's probably 1 in 100 where I do feel something. I didn't notice it before. I comment on it. Sometimes it's MRI visible, sometimes it's not. And it's certainly something that we target on biopsies when we feel a nodule on one side. So I would stick with it, but I don't think we can argue for it in the screening population.
Gotcha. Jeff, why don't you throw
Sure.
out 2 fastballs?
Thank you, Howard. Good evening, good afternoon, good morning, wherever you are. I'm Jeff McLennan. I'm a board member of ASPI and a good associate of Howard's. I live in the land of earthquakes, which is known as Northern California. One of the broader approaches that I'd like to ask each of the panelists today has to do with the family health history. Now, I grew up in families that were very secretive. People came in with a broken arm or something, fine, but a lot of my relatives did not, particularly the men, did not want to talk about, you know, their family health history, particularly if it came to do with the prostate. And of course, now we're learning a lot through the genetics and the genetic tests. And then finally, I've actually had some doctors tell me that they're not trained in genetics and therefore they can't answer my questions. Now, each of you doctors, how can we evolve from, you know, the old-fashioned secrecy and also the medical laws in each of our nations and states? How do we break through family health history and get to the hard facts of genetics without disturbing people?
So I really think for the most part, there are GINA laws, and those are Genetic Information Protection Act laws, if you will, that really support and are put in place so that genetic information cannot be used or held against you in terms of medical coverage, period. So that there is very little downside, period, unless you are going to report this. And they never ask this specifically. They do usually ask about family history to life insurance companies. Life insurance companies are very, very different. They are not medical companies. They're not insurance companies. So just keep that in mind. But on the other hand, from what GINA does support is that if you do genetic testing or do gather information about family history, that will not be held against you, period. And as such, you know, these type of genetic tests that we're offering or that are available are not a absolute, right? If you have a mutation in a gene such as a BRCA2 or HOXB13 or some of these other genes, it does not mean that you are going to get prostate cancer. These are all relative risks. And yes, you have increased risk, but it is not opening Pandora's box. So explanation to family members, making them understand that these are just probabilities. And if we know that you have increased risk of X disease, we just want to make sure that you are screened earlier for this, so that if you do develop that disease, which you have that susceptibility for, that it is at a time when it is very treatable. So I think once you explain that to family members, that this is not going to be held against you, it's not opening Pandora's box, that this is possible. And the other part about this is that, the current system is really, is developed based on family history. But again, a lot of people don't have that opportunity because of early, deceasement of their family member, or no one talked about it, or certainly if you're adopted or things like that. And so that's really where genetic testing becomes agnostic, is to say, I don't care what your family history is. If we see that there is a mutation, we can then screen you better or help you in various ways along this journey. And that's really where a lot of these polygenic risk scores are developed, is to say, again, way better than a family history, I can really better estimate your risk of certain diseases. So that's really where I see the opportunity to come and really inform people to say, hey, get involved. Talk about this with your family members. Even if you do or don't have that family history, do consider genetic testing.
So around the Thanksgiving table. Thank you, doctor. Other doctors, would you like to comment on this subject?
I would just say that, the family history of your first degree relatives is the most relevant, because you share the most genetic information with them. We're talking brothers, sisters, father, mother, children, although, yeah, again, you're not getting anything from them. So I would think that is readily available, unless, as Dr. Helfand said, someone's deceased or not available for comment. And I see it as a three-legged stool at this point. I'm sure there'll be more legs, but you have family history as one pillar of information. You have the SNPs, or the whole genome profiles, and then you have the rare mutations in some of the known predisposing genes. And we'll probably get more predisposing genes over the next decades. We'll have better and better genetic inheritance assays, these polygenic risk scores, and we'll get drilled down on more discrete family history as people, with larger families, or with or as we learn that other cancers may or may not increase your risk of prostate cancer. So I think it's important to get a family history. I drill down on first degree relatives. And in surveillance, certainly for cancer detection, men with family histories are found to have more prostate cancer, although there could be several reasons for that. But in surveillance, there appears to be a signal that men on surveillance with family histories may have slightly higher risks of progression than men who have no family history. That's different cohorts have looked at that. It's sort of a small factor maybe, but it's worth putting into your list of risk factors, as Dr. Helfand said. One of the things taken into consideration, probably higher than digital rectal exam, but lower than your biopsy amount of cores and grade, for example.
Thank you, doctor. Doctors Epstein or Showalter, do you care to comment?
Not something in my bailiwick, so I'll leave it to the clinicians to discuss.
Yes. Okay. All righty. That appears to be it. Howard, somebody else's turn.
David, do you want to weigh in?
Yes. Welcome, everybody. Thank you, doctors, for your incredible presentation. This has been very, very helpful. I think everybody on AS should review this. There's so much good data here. I'm David Keller in Jacksonville, Florida. I am a prostate patient advocate for people that are on low to intermediate. And I'm also on the advisory board for Active Surveillance Patients International. And I've done some published work in the field of prostate cancer. I have a question for all the doctors, and that is, well, let me ask my first one. It's very pressing with Dr. Epstein. Should the patient have a checklist on what they would like to get from their pathologist? Because as you said, many of them aren't providing certain data, like the percentage of the pattern, the cribriform, intraductal, perineal invasion. Would it benefit all of us on this call and other AS patients to literally submit a checklist to their pathologist of what they'd like to get feedback on.
Yeah, so what I would say is, and along those lines, is, and I think all the men who are on this program obviously are informed prostate cancer patients and are interested in being as informed as possible. And that's the first step. So I think it is critical that you keep that checklist, at least yourself, have that checklist. And when you get your pathology report, if those items are not on the checklist, you have a couple choices. You can go back to your urologist and tell them, how come they didn't mention intraductal cancer? How come they didn't mention perineural invasion? They didn't put percent pattern 4. Can you get that information from the pathologist? Probably easier dealing with your urologist to then go back to your pathologist. Or alternatively, say, if that pathologist is not giving me the critical information, can I kind of trust everything else that's in the report? And the alternative is to get a second opinion. But I think it's important for patients to know what should be on the report. And if those factors are missing, that's kind of a red flag.
Okay, thank you very much. Dr. Helfand, what are the actual steps if someone wants to get the Artera AI report? Is it you simply ask your pathologist to send a biopsy over to Artera? What are the steps?
We have Artera here represented. They could answer too.
I was going to say, I'll let you.
Excuse me. I'm sorry. Forgive me.
Well, ironically, I've actually never ordered one because I can't in my role. But yeah, so basically you would speak to your treating clinicians, or your urologist, or your radiation oncologist, or medical oncologist if you're a patient, and the order would go in by the physician or their staff. And ultimately what happens is that the Artera team takes it from there and would contact the pathology lab that has that biopsy specimen. And our lab, which is based in Jacksonville, Florida, would request that a H&E stained biopsy slide that represents the highest grade tumor be shipped to our lab. The slide is scanned at our laboratory on a specified scanner that the test has been validated on. And then the results are processed and they're generally sent back to the ordering clinician the next day. So pretty fast turnaround time.
David, you could walk it over to their lab.
Yeah, that's true. Excuse me, Dr. Showalter, I know this question was for you. And could you tell us what H&E means?
It's homoct. It's the standard stain.
Okay, thank you.
What is it?
Just a technical term.
Dr. Epstein should tell us, actually, so we should tell.
Thank you so much.
Hematoxylin and eosin, I think. So.
I'm sure a lot of us are interested in getting that updated report from our latest biopsy. I have a question for all the doctors, and maybe any one of you may have the best answer, but as a patient, we get every 6 months or a year, we do our blood draws. And my primary care provider, he'll take suggestions from me on which blood tests to get other than the standard PSA. Which are the top 5 or 6 should we be asking for? There's the PHI, there's my prostate score, there's 4K. There's a number of them that have been presented to us. Could one or more of you make a recommendation on so that we get a good overview on what we can learn? And if some of these are urine, let us know, and maybe saliva. I think some of us, like me, I'm getting ready to do another round, and I'd like to tell my doctor which tests I'd like him to put in for.
Let me grab that and just say that, and I think Dr. Helfand will agree with some of what I say because our practices are comparable. I like, in addition, in lieu of a PSA, we get PSAs every 6 months, maybe once a year. I would get the PHI, which gives a little more information, PSA, free PSA, and pro PSA, and it is not quite very expensive. The 4K adds a 4th marker and is significantly more expensive, maybe 3-fold. And really although there have been no head-to-head published reports, we have done some head-to-head and not seen a difference in the utility of 4K versus PHI. So for the PSA-based isoform tests, I'd get a PHI if one can get that in your area. It's not available at all labs. 4K would probably be because it gets shipped to, I think, somewhere in New York. In terms of urine, I think what's on the market is not all that helpful. We have not shown PCA3 to longitudinally really help predict progression. That's one of the older urine tests. We're looking at ExoDx, if that has a role, the EPI test. I think the new one coming out of the data is coming out of Michigan, but it's called, I think it's My Prostate Score 2.0, MPS 2.0, which we haven't run yet, but the data seem exciting about that one because it's a more multi-gene panel. So I would say, if you could ask for something, PHI and maybe MPS 2.0 for urine. I like having something PSA related and something not PSA related. Just my 2 cents.
Yeah, I think
Anybody else want to comment? Go ahead.
I 100% concur in everything that was just said. I think understanding that many of the tests out there haven't really been evaluated in the active surveillance setting. And that's very important because, again, just because you have prostate cancer, we know we're really looking to see, is that result associated with outcome in terms of the risk of you having a higher grade tumor in there. And certainly when it comes to things like prostate health index, and I'm sure 4K or even ISO PSA, that you're going to be able to monitor for changes over time, and the actual value as actually predictive of what happens over time in active surveillance. I think ultimately one of the biggest limitations that we have is availability. I think we're very fortunate that we can order these tests. They're done at our institutions. It's not a problem. But again, when you look at reimbursements for this, they're really not good. So a lot of institutions don't support them. And even though, again, when you compare it to PSA, which has very little prognostic value in terms of active surveillance, and that is what's actually in the NCCN in terms of how we monitor patients on active surveillance, even though it doesn't have that prognostic value, I do encourage patients to look for other supplementary tests that may be more informative in terms of how your tumor is actually progressing and or not progressing.
Could I jump in here? Let me ask in terms of age stratified. Okay, I'm an elder, don't mind sharing it, 71,
Hey, Sonny, you're not that old.
I'm lucky at this point. I've lost a lot of friends. How do doctors stratify treating younger men on active surveillance versus the older men, treating and or watching?
Well, big question. I mean, when this program, this concept was started early on, 90s, 2000s, it was for older men. We said men 65 and older because, God forbid, a young man has progression. We didn't understand Gleason 6 as well as we do now in terms of its long-term oncologic risk, which is quite minimal, if at all. So things have changed. And what we now learn is it's really the older men who are more likely to have higher grade, higher volume cancers that progress, not the younger men. The younger men's problem is that they don't really want to be on surveillance for 40 years and get, 22 biopsies over the decades. So AS is onerous for the young, and they can be cured and usually have great outcomes with radical prostatectomy at that age. Older men, less likely to cure, more likely to be harmed by the cure. So, it's a very complex answer, but I think the take home is AS is very much open for young men. They have to be accepting of it. We have to accept it for them and offer it. They are going to have more, investigations over the years because they have so many years to live. And but they should be included in the eligibility criteria. Older men, I worry about because they get new cancers, worse cancers, progressive cancers, et cetera, and then others have these long, low-grade Gleason 6s that never progress. I'm hoping we're finding fewer of those in the MRI era, And I think there's data to suggest that, that we're finding less Gleason 6. We're enrolling fewer men on surveillance with small volume Epstein criteria Gleason 6. And we shouldn't throw the towel out and say, you're older, we don't need to monitor you, we can de-escalate, unless truly the parameters that we're following are all favorable for the 75, 80, 85-year-old man, in which case a transition to watchful waiting can be very appropriate.
So Dr. Helfand, you gave us a lot of information. Thank you. And the same question, what about these repair genes? Have I read that, well, obviously, as I grow older, my parts aren't going to work as well, including my RNA and DNA. How does an older man protect himself, if you will, and get the clinical treatment he may need as these genes tend to fall off by the wayside?
So, what I think you're actually coming to or hinting at here is really kind of tumor progression, right? Because ultimately, for the most of us, right, when you're born with DNA, it doesn't just sporadically change in every cell to something. So what you're really saying is what is actually happening in your tumor. And again, the good or the bad is that most of these tumor DNA mutations in tumors specifically, again, referring to what I previously said are called somatic mutations, they occur and accumulate very slowly for the most part. Meaning if you're just watching a tumor, because prostate tumor cells divide so slowly, even though it's still a tumor, even if because their division is so slow that you're very unlikely to develop new somatic mutations on their own over time in the active surveillance cohort. Now, that's very different if we're talking about a man with advanced prostate cancer whose cells may be turning over faster and or influenced by exposures to things like hormone therapy, which we may actually provide selection pressures that select for a lot of these type of mutations, totally different. But if you're going to say the average man on active surveillance, what can you do to, decrease the probability of you developing new mutations? I don't know if there's a lot, but this is where we go back to lifestyle. And again, looking at the dietary recommendations, looking at the overall lifestyle exercise recommendations, the alcohol recommendations just came out yesterday. I think it's things to consider that, the better we treat ourselves, the less toxins that we expose ourselves to, the better outcomes that you may have.
Hey, Jeff, I'm going to take it now. We're at the official ending time, but I'm hoping that we can maybe continue for another 20 or 30 minutes if the doctors need to go. I don't have police powers. I can't stop you, but I hope you can. I hope you can stick around. At the ASPE group later this month, we're holding a meeting with Dr. Mark Emberton from England, and we're going to mainly be talking about MRI-invisible lesions. I'm going to put in the box where you could sign up for the meeting, but I'm wondering what are these invisible lesions? How common are they? And why do you guys think that they're a good thing? Invisible sounds like a threatening thing. And also, in Dr. Epstein's world, does any of this matter? So, any takers on invisible lesions?
Yeah, what I'll tell you is that MRI will only find things of a certain size. Okay, so invisible means in general small. MRI is also not a biomarker, so it's dependent on the reader, and it's dependent on the location and when the dye is injected and when the sequences are taken. There are a whole host of things that make an MRI crappy or high quality. An artificial hip can affect the quality of it. So it's not like you walk in, you get a PSA, it's an objective value from the day. It is a complex exam and is read by folks of varied expertise. So I'll tell you what happens in AS at Hopkins, where historically about half of our men just didn't have a lesion and about half of men did. So half of these Gleason 6s we don't see, and half we see something. And of course we have some 3+4 patients now as well. Generally, these are smaller amounts of cancer, and that itself is somewhat prognostically favorable. But sometimes, something that's shows up on surveillance on MRI. And so then we show the radiologist and say, was this really not there on the MRI 3 years ago? And they say, actually, in retrospect, I see something there. So then is it really invisible? Was it invisible? Or was it just underappreciated? Certainly, I'm sure one could pool 100 radiologists and they'd all agree that these men have nothing visible and these do, but there's a huge gray zone. So I wouldn't put, it's still a developing field. It's certainly better to have an MRI that appears normal than one that doesn't. But it's not the be all end all. And sometimes you can catch very high grade small lesions, not seen on MRI, affect a cure with radical prostatectomy or radiation, and really cure the Gleason 8 patient. Whereas if you waited till it became MRI visible and it would high grade, that would not be as curable.
Dr. Helfand, do you have something to say?
Yeah, I concur in a lot of this, even though, again, MRIs have moved the bar significantly, but they are still not perfect. And again, while they have their limitations, the limit that you can see is about 4 cubic millimeters. And that it's not microscopic, and it's certainly never going to equate to histology, pathology we see in the microscope. So we need to understand that there's always going to be, as it stands even right now, a sampling error. And, what I think worries me, worry is all relative, but, why I always target visible things that we can see, but also the, kind of invisible areas as well on biopsies is because about 30% of patients will be upgraded in more aggressive tumors in that invisible area. So is it something that you should worry about? No. But is it something that, again, if you're there, that you should sample? Yes, because again, the more information that we can get, whether it is specifically from those visible areas versus the invisible, I think that you should check it out and get that information.
I wonder, Dr. Showalter, how these invisible lesions fit into the AI world, or if they don't. Maybe Dr. Showalter left us.
I don't see him.
Okay, and Dr. Epstein, does invisible, you find them. How does it feel to hear that the MRI doesn't see them? Your microphone is off.
Yeah, the majority of times, the higher grade lesion will be that sampled by an MRI targeted lesion. So there's no question having an MRI guided biopsy is an improvement over not having an MRI. On the other hand, it is not infrequent at all that sometimes the higher grade component may not be seen on the targeted biopsy, which is why, again, you need that broad sampling of the entire prostate. It's also not uncommon for a targeted lesion to not show cancer. It's very, very common. I think it's very unclear at this point what makes a lesion, stand out on the MRI, why there are some higher grade lesions that are invisible on MRI. We just don't have, I think, a great knowledge of, what makes a lesion visible and not visible. We have some idea, but not completely.
Hey, David, why don't you go?
Yeah, just to follow up right on that, the visibility part, there's been a couple of questions on ultrasound, exact view and things like that. And I thought I read that there was one study that showed that ultrasound actually picked up on something where an MRI missed it. So do any of the panelists have comments about ultrasound testing?
Yeah, I mean, it is one of those where it's a different platform. It's a fancier, if you will, micro type of ultrasound. It, can, and for experienced users, pick up on, kind of different potential lesions. Again, they haven't really gone head to head for the most part in a randomized trial. But it is a different modality. And again, whenever you use different platforms, you can pick up on some things that another platform may miss. And so does that make it better overall? No. It just means that it's different. And again, I think it's an evolving area. And I think imaging overall, whether it's MRI, whether it's using PET scans, whether it's using ultrasounds, I think a lot of this, again, is starting to merge to see, hey, what tools can we do in a cost-effective manner? How can we combine them, et cetera, to really make biopsies so that they limit the amount of undersampling. I think that's the exciting things that are coming forth, but we're not there currently.
Thank you. We really appreciate it. Howard, I have 3 other questions, one on PSMA, one on nocturia, and one on BPH. Would you like me to ask them?
Well, I think we are overwhelmed with the number of questions, or we're probably not going to be able to answer them all. Dr. Showalter did leave, and he left an email. I don't know if the remaining doctors would be willing to respond to questions either funneled directly to you or funneled through me. I don't, I can do whatever you want. If you're willing to share your email addresses, doctors, feel free to put it in the chat. If you don't, that's your privilege. And I saw somebody had asked for Dr. Epstein's contact information. I don't know if you want to funnel that through me or if you want to just post it directly in there. I don't think you put your slide up, Dr. Epstein.
Yeah, so I can put up my slide if you want to just give me the share.
Yeah, Bill, are you still around? There we go.
Yeah, so within the next couple of weeks in my new practice, I'll be opening my urological pathology consultation practice. It'll be rapid turnarounds within 24, 48 hours. As I've always done, there's an opportunity for patients to talk to me once I've reviewed the slides and discuss their cases. And then we FedEx return the slides to make sure that they're available if somebody needs the slides to go elsewhere. But we're setting it up. It's just a matter of figuring out some billing issues and some legal issues. But hopefully within 2 weeks, we'll be ready to receive consults.
Well, I'll share that information when you're up and running. I wanted to bring, I realize that we have a diverse audience in terms of the grade groups here, and we have some men with more advanced cancer. I mean, generally we talk mainly with the active surveillance audience, but I wanted to see if I could ask a couple of questions for the guys with more advanced disease. I knew Richard here from back when he was on active surveillance. For all I know, Dr. Pavlovich, he might have been one of your patients. He was at Hopkins. He mentioned, let's see, he says here, is he a lone wolf? Well, he's not, although we may have lost some of the other lone wolves. He says, I would like to know how to monitor prostate cancer following radiation treatment. Unfortunately, we don't have a radiologist here. We have everybody else here, but maybe in a generic way, somebody could answer how to monitor after radiation.
Yeah, I mean, PSA is generally the easiest way. Successful radiation will get your PSA down to the 0 to 0.4 range typically. And then if it starts rising, we look at kinetics, doubling time, and we worry when that doubling time is less than, say, 10 to 12 months. So, 0.4, 0.8, 1.6. A PSMA PET scan would be the classic next step for folks with radiation recurrent disease. And if that disease is found outside of the immediate prostate, then, of course, there are hosts of chemohormonal therapies or targeted metastasis-directed therapies. If the disease is found in the prostate, we would suggest a biopsy guided by the PET scan and or MRI, and then one could consider ablation with cryotherapy or other technologies of the recurrence in the prostate. So I don't know if that answers the question.
The other issue, just to keep note, is when you get, typically you'll need a biopsy to document that cancer has recurred. And there's two types of cancers you can see following radiation. If the cancer has been successfully treated, the cancer will show certain changes that mimic high-grade cancer. So an inexperienced pathologist would say that's aggressive cancer, where in fact that's treated cancer, which will do well and doesn't need further treatment. On the other hand, if the cancer shows no treatment effect, then you grade it just like you would normally and decide how you go going forward.
So David, you want to throw out a couple more? And then Jeff, if you have a few more.
Yeah, I have one.
David, your microphone is off.
Sorry about that. Two PSMA types were mentioned. One is the 68GA PSMA 11 PET CT. How useful is that? And there's one that a study was done on PSMA PET 18F7Q, which showed some benefits in the first study because the marker was secreted out through the liver, not through the kidney, and therefore you didn't have the artifact issues. I didn't know if any of the panelists wanted to comment on PSMAs in general and the potential future of PSMA eliminating the need for a biopsy.
So another topic I'm very fond of that, currently PSMA, and for those of you who don't know, is a molecule that's expressed by prostate cancer cells. Its expression is very uniform, although certainly as tumors progress, may or may not, the expression of PSMA may or may not be influenced by exposures to hormones, et cetera, or certainly de-differentiation of cells where they may not express it as the tumor gets worse. And so knowing that most prostate tumor cells will express some degree of PSMA, there have been what we call next generation or more advanced PET imaging techniques that have used various molecules to detect PSMA. Gallium was one of the first in this space to look specifically at PSMA. Again, this is following years of work in PET imaging, but specifically in terms of PSMA, one of the first out there. It's easy to administer, doesn't need a large machine, if you will, to manufacture this. So a lot of this can be implemented at many sites, kind of in more real time. However, as you said, is the PSMA, the gallium PSMA is expressed in urine. So it goes and processed a lot through the kidneys, which ultimately is excreted through the bladder and prostate, if you will, tissue. So there is some skepticism that you may be missing some of those kind of local recurrences if you had a prostatectomy or your prostate's still intact, just because as the PSMA agent is processed and excreted, it may actually interfere with some of your interpretation of those images in the pelvis. Some of the other agents out there, the flucyclovine based agents, they are a little bit more or less excreted by the kidneys, processed, a little bit more by the liver. And so they may have better visualization of that. There is an ongoing trial that is just starting specifically in that space to ask that question. However, we again don't know the comparison or if one agent is better than another in that space. And again, we will ask that. I do think, again, they have moved the bar in terms of localization of prostate cancer and certainly of, kind of prostate cancer that has become metastatic or recurrent. I do think, again, a very exciting space because I think as the agents, radio tracers for these are progressing, and we understand more of the biology, we'll be better equipped to come up with concoctions that may be able to find these tumors even better. But right now, if you just use that as a sole localization, and I don't think it's ready to replace any type of MRI or biopsy, it doesn't give us any degree of histology or clue what's actually happening in a tumor. It may suggest that there is a tumor present, but again, even that's not perfect at this point. So we still have a long way. And again, comparative cost, the effectiveness of PSMA alone as a agent is way less cost effective than the current MRI fusion techniques.
Thank you very much.
Okay.
I think maybe we should call it a day. And, I really appreciate everybody coming out. I appreciate the doctors who are here and the doctors who are no longer here for their time. I haven't been able to monitor the chat, but I don't know if you want to pass along to me any contact information for further questions, or if you don't. And I think we should. I mean, there's just too many questions here, and so I'm really appreciative to everybody who came out and everybody who asked a question and everybody who didn't ask a question. I'm grateful. I'm wishing a great 2025 to everybody. And maybe we'll do this again. I sent out a questionnaire earlier. Appreciate it if you fill it out. Be gentle on me. You can be tough on the doctors. Anyway, thanks for everything. So
Thank you, Howard, for arranging
Thank
it.
you.
Yeah, thank you, Howard, for putting this together, and we really thank the panelists. You guys were terrific.
Yeah, great show. Great show.
yeah, thank you.